Thank you. Yeah, I will start with the same note that Ranjana was just speaking about, that how it has enabled many gynecologists who were having either difficulty or not able to perform complex gynecological procedures with the use of conventional laparoscopy. And myomectomy definitely has become one of those surgeries. So what we did is actually we did some kind of analysis of our study of robotic versus laparoscopic assisted surgery for myomectomy. Why was this study planned? Now, I planned this study in my unit because I wanted to understand whether the laparoscopic and robotic approach were comparable, and if so, in what parameters. Number two, to analyze if robotic assisted can replace laparoscopic assisted myomectomy in the long run. Is there a benefit of doing robotic over LAM? And this is a tertiary care private center. We get a lot of difficult large myomas, and the study period was between June 2012 to June 2015, in a period of two years. Now, how did we select the cases for these two procedures? Simple, once we had the robotic technology, and I found that myomectomy was one of the surgery which I really loved to do it because of the suture intensive procedure, and I felt I could probably do better than what I was doing laparoscopically, to be very honest with this audience. So what I did, I just explained the advantages of robotic assistance to all the patients who approached me for a myomectomy, and I offered all of them robotic surgery. However, if the cost was not the issue, because that was the issue to start with, the patients were posted as robotic surgery, and if the cost was an issue, that patient went back and opted for a laparoscopic myomectomy. The technique I will describe here as a comparison is not a laparoscopic myomectomy, but a laparoscopic assisted myomectomy, because the patient population that we had huge myomas, had multiple myomas. We are probably either famous or notorious for that kind of referral to our hospital. So the position of LAM, or laparoscopic assisted myomectomy, was this, in the Trendelenburg position, and these were the incisions that we made, 5 mm basically to do the myomectomy, third one if required, and then we made a small suprapubic incision which would not be more than 2 or 3 inches, and we now do intracorporeal suturing of this myoma bed after the myomectomy is over. Do not take the uterus out of the abdominal cavity. This is the final result. These are the laparoscopic ports. That's a small suprapubic incision, and that's the amount of myoma that is removed. So we rely on the sound surgical judgment and honest assessment of what we can do, especially for reconstruction of this uterus after we remove the myoma. So we chose to do LAM in these cases rather than laparoscopic suturing and myomectomy for these patients. The technique for robotic assisted position is the same. These are the ports that we use: arm 1 for hot shears, arm 3 for tenaculum, and arm 2 for bipolar forceps, and an assistant port to either do suction or to pass my needles. And we keep about 10 centimeters distance between so that the arms don't clash. Hysterotomy is done by vertical or transverse incision, enucleation done, and then suturing by using V-lock. The results. Now we compared 76 patients, of which 40 were robotic assisted and 36 were LAM. This is about 6 months back this statistical analysis were done. However, we have now reached about 69 cases of robotic assisted myomectomy in our center. We compared their age, presenting symptoms, blood loss, operative time, fibroids, the number, weight, and the post-operative data. And we did the amount of blood loss was assessed as the drop of hemoglobin in the first post-operative day. If the choice of operative procedure had any effect, that was what we were trying to study. We wanted to see if it made a difference in the operative time. Now, what I realized is that this study period also included cases of our learning curve. So what I thought is, if I include that, automatically it will reflect the same surgical data or data coming out from everywhere, that robotics takes more time. But what I wanted to prove is that the surgical time is not different, or probably that's what I felt, and the study also correlates to that. So we took the console time for the robotic cases, and we took the surgical time in laparoscopic cases by subtracting about 20 minutes, which we require for induction and putting the patient in position. Then we checked for the blood loss, number and weight of fibroids, post-operative anesthesia requirement, hospital stay, and we did a Mann-Whitney U test to see what could be the significance of this data, and the data analyzed was non-parametric, and that is why we chose this statistical analysis. If you see at the epidemiological factors, both the groups had similar findings, was not different. There were no DVT or pulmonary emboli in either of the cases, no conversion to open surgery, no hysterectomy required, as we sometimes counsel the patients for myomectomy. Then we started doing the summary of the continuous variables. We find that IV requirement, analgesics, stay in the post-operative period, and the weight of the fibroid were a little different between the two cases. When we tried to do a detailed analysis, we found that the standard deviation was different. Now we had a large standard deviation, which meant that some of our cases were having large size of fibroid. So there were some outliers. What we did is we reduced some of the patients in which the fibroid weight came out more than 1 kg. They were large myomas. So that was not giving us the correct statistical analysis, and after we did that, the number 9 cases were excluded between the two groups. So we reanalyzed after removing the outliers, and we found that the requirement of IV analgesics, the post-operative stay was significantly less in patients who underwent robotic assisted surgery, and the number of fibroids removed were more when we did robotic assisted surgery. This is some of the comparison of other data that have been in the literature, and most of you can actually go through it. But despite these results, most groups who have presented this kind of data have come to a conclusion that easier fibroid enucleation, layered closure, lower number of uterine incision required for removing the fibroids, and more and weight number of fibroids is definitely an advantage when we use the robotic assistance. Let's just analyze some of the results. Now when we talk about blood loss, we found not significant between the two cases, between the two groups. However, I feel that it could be because it was the same surgical team, the same technique used like vasopressin, the same amount of vasopressin injected, use of tranexamic acid at the induction, and use of microsurgical principles, whether it was robotic or laparoscopy, because the same surgical team had long experience in laparoscopic surgery as well. And we use either an aspiration needle to directly do vasopressin, or use a spinal needle or a Veress needle transabdominally to do that. But we further analyzed this blood loss operative as a regression analysis model when we compared it to the operative time, the fibroid weight, and the number of fibroids. Although the conclusion is that the robotic assisted expected blood loss was little less than the laparoscopic, it was not clinically significant. So the reduction is there, but maybe a larger amount of data is required to be able to come to conclusion that yes, because clinically we do feel that when we do robotic surgery, because of the microprinciples and the hemostasis, the amount of blood loss is much less. Results in operative time, as I said, we exactly compared the operative time and not the ancillary time, because we understand that the extra time required with the movement of docking is impacted not just by the surgeon and the surgery, but also by the training of the staff and your OR team, and it improves over time. Again, a regression analysis of operative time showed that if we, any case where extra number of fibroids were removed, we improved or we increased the time by about 10 minutes each extra fibroid. So if there are 4, then certain amount of time, and if there was 5, another 10 minutes was required. The difference between operative time of the two groups was insignificant. So the actual operative time is not significant in the hands of experienced surgeons. So the choice of procedure has no effect on the amount. So if we control or if we can reduce our extra OR time, the morcellation time, the docking time, then our robotic surgery is actually not significantly higher in terms of the operating time. I could not find a correlative data comparing the myomectomies, but I did find a study in which the operative time was significantly longer in patients undergoing robotic hysterectomy when compared to laparoscopic. But when they also did a regression analysis, they found that actually the extra time was for morcellation in patients with high BMI, in patients with uterine weight, and not exactly the robotic surgery console time that added to the extra time that was required. So this is probably an important information or assessment for us to now understand that robotics always does not mean increased operative time. The requirement of analgesia was significantly lower in robotic cases. The question is why? Both are minimally invasive. My understanding for that is that when we do a robotic surgery, the movement of the hand instruments that we make is not, the fulcrum is not at abdominal wall. But when you do a laparoscopic surgery, the fulcrum is at the abdominal wall. So we tend to move our instruments right, left and center, and the fulcrum is at the abdominal wall, causing more tissue drama at the port site. But when you do a robotic surgery, the fulcrum is at the wrist. So the robotic instruments do not damage so much at the point where the entry of the port. And that is why the pain in these patients is much less. And of course, there are studies which evaluated that narcotic use post-robotic surgery is much less. Post-operative stay. We found a significant difference in post-operative stay The question is, was that a biased decision on our part? Because we did robotic, we were more keen to send these patients home. We are actually also sending robotic patients now as a daycare basis. Less pain these patients had, so that led to earlier discharge. Reduced tissue destruction using finer instruments. Did that cause better post-operative outcome? I am not sure. We need to probably study that more. Limitations of my study: retrospective, smaller number of cases. We probably can include more, maybe do multicentric study, give more data to this data. Bias in selection, because selection criteria was not unbiased. It was depending on the patient's ability to pay, unfortunately. So different techniques will coexist. This is an editorial published by Dr. Roy Pitkin in 1992, where he made all these questions about minimally invasive laparoscopic surgery. But the same doctor in the Green Journal, 18 years later, commented that laparoscopic surgery has come to age. So I think technologies change. We need to move with the technology and see and do comparative study to see whether it's making a difference to our patients. Thank you so much.